Hey everyone, my name is Mayar. I am a current ENT applicant. This cycle, I just finished up all my sub-I rotations and I compiled all my notes into a little notebook, which I kind of just formed into a Google Doc, and I just figured it would be kind of cool to share all the things that I kind of wrote down the last couple months. They're just some high yield facts that I just felt would be good information. So if there are any mistakes, please feel free to correct them in the comments below. And please like and subscribe, and thank you all so much. All right, so I just figured we divide it all up based off of course, ears, nose, and throat. But I actually started off with head and neck cancer. So we're going to start off with what are the layers of the epidermis? So a mnemonic that I use is Corny Lucy's grandma, her spine broke. So I had stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale. And then another important thing is to know the levels of the neck. Another commonly asked question, I got this a lot, was what are the layers of the scalp? Luckily, there's a mnemonic that is literally scalp, and that's going to be skin, connective tissue, aponeuroses, loose areolar tissue, and periosteum. Another question that you may get is what are the 8 branches of the external carotid artery? And I was asked this several times. And then this is superior thyroid artery, ascending pharyngeal artery, lingual artery, facial artery, maxillary artery, occipital artery, posterior auricular artery, superficial temporal artery. What is the most common type of benign parotid mass? And that'll be a pleomorphic adenoma. And then you may also be asked, what is the most common type of malignant parotid mass? It is a malignant mucoepidermoid carcinoma. And then what is it called when your parotid gland is inflamed? That is sialadenitis. And if you have a stone or obstruction, it will be called sialolithiasis. And then another common benign parotid mass, the second most common, is what? It's a Warthin's tumor. What is that also called? And the actual technical name, and I was also questioned on this, was papillary lymphomatosum cystoadenoma. What are 3 commonly tested pearls or questions about Warthin's tumors? 1, it's common in smokers. 2, it can occur bilaterally. And 3, about 10% occur bilaterally. Another one is what are the names of the openings of the salivary glands within the oral cavity? For the parotid gland, it is Stenson's duct. For submandibular, it's Warden's duct. For sublingual, it's the ducts of Rivenus. Let's say you have an adult that comes to you with a chronically infected neck mass in the midline, with no weight loss, no signs of malignancy. What should be on your radar? That would be a thyroglossal duct cyst. Now, what is the procedure that removes a thyroglossal duct cyst? It's a cyst trunk procedure. Where can a thyroglossal duct cyst occur? It can occur anywhere on the thyroid descending tract. So from the foramen cecum. Now, what is the foramen cecum? It denotes the posterior 1/3 from the anterior 2/3 of the tongue. And it can go from the foramen cecum all the way down to where your thyroid naturally would descend to. Where does it most commonly occur? And it occurs just inferior to the hyoid bone. A commonly asked question during the procedure is that an attending may look at you and say, why is it important that we stay medial during the procedure? And that's to avoid injuring the hypoglossal nerve that is located laterally. Let's say the attending asks you, in addition to a thyroglossal duct cyst, what are some other benign masses that can occur in the midline? A few are dermoid cysts, teratomas, goiters, and lymphoangioma. And I was also asked, what is the difference between a dermoid cyst and a teratoma? A dermoid cyst is made up of ectoderm and mesoderm, while a teratoma is made up of all 3 layers. Let's say you are conducting a surgery on a parathyroid adenoma and you're removing your parathyroids. What % of PTH should drop after a parathyroidectomy? About 50% should drop in how much time? In about 10 minutes or so. What are the 4 strap muscles? It is sternohyoid, sternothyroid, omohyoid, and thyrohyoid. A question also that may be asked is, what is the innervation of all of these? And that is the ansa cervicalis, which is comprised of what 4 nerves? That is C1, C2, C3, and C12. But one of those muscles is not innervated by the ansa. Which one is that one? That's the thyrohyoid. And that's innervated by just what? C1. Commonly asked question is, what is the difference between a barium swallow and a modified barium swallow study? The modified barium is just of the throat. What is the most commonly seen skin cancer and how is it treated? And also, what versions of it are the most aggressive? Basal cell carcinoma is the most common. It's treated via wide excision, and the most aggressive versions are the desmoplastic and the basosquamous. Another commonly asked question is, what makes up a radical neck dissection? It's 4 different things. It's, well, kind of, but it's lymph nodes in levels 1 through 5. It's the SCM. It's your IJV, and then it's your spinal accessory nerve. What is the symptomatic presentation between peripheral facial nerve palsy and central nerve palsy? A central unilateral lesion will spare the upper face, versus a peripheral lesion will involve both the upper and the lower face. What are the 3 segments of the facial nerve? That's labyrinthine, tympanic, and the mastoid segments. For a thyroidectomy, what is Barry's ligament? Barry's ligament attaches the thyroid lobe to the trachea, and usually you'll see the recurrent laryngeal nerve running very approximate to this. What are the 3 main different types of multiple endocrine neoplasias? These are your men 1s, your 2A, and your 2B. So remember, for men 1, it's just 1 letter. It's all P's. So you're going to have parathyroid hyperplasia, pancreatic tumors, and pituitary adenomas. For men 2A, that's going to be a mix. So that's going to be MTC, for medullary thyroid carcinoma. And then you're also going to have pheochromocytoma, and then parathyroid hyperplasia. For men 2B, remember that this is almost all M's. Besides pheochromocytoma, it's also going to be MTC. It's also going to be mucosal neuromas, and it's also going to be marfanoid habitus. My favorite procedure is, of course, the Inspire procedure, and these are some commonly asked questions about it. So what are the tongue protruders? That is your genioglossus and your geniohyoid. What muscles are your tongue retractors? Those are your styloglossus and your hyoglossus. Your digastric muscle will eventually be exposed during the procedure, and a commonly asked question is, what innervates the digastric muscle? It's a trick question because anteriorly it is innervated by V3, and then posteriorly it's innervated by 7. What are the indications, or at least the criteria, that need to be met in order to conduct an Inspire procedure? First, you need to undergo a DICE and make sure that there's AP, anterior-posterior collapse, and you want little to no circumferential collapse. And then now, this just changed. It used to be 33, but now the BMI that you need to be under is 40. It used to be, I believe, 33. And then you need less than 20% of your sleep apnea to be central, so you need less than 20% central sleep apnea. And then the patient needs to be at least 21 years old as well. And then it's good to also know what is a high AHI score. So know that in kids, at least, 1 to 5 is mild, 6 to 10 is medium, and then greater than 10 is severe. Versus in an adult, anything less than 10 is mild, anything between 10 to 29 is considered medium, and then anything greater than 30 is considered severe. Moving on to the oral cavity, what is a bony overgrowth of the hard palate called? Torus palatinus. What is a common complication after a parodontectomy? It's Frey syndrome. And you may also be asked, what kind of test will test for this. It's a starch iodine test. This is probably one of the most highest yield questions you'll get is, what are the arterial branches of the tonsils? So there's going to be 5 of them. It's the tonsillar branch off of the facial artery. It's your ascending palatine branch, also off of your facial artery. Your descending palatine branch off of your maxillary artery. And then you also have your ascending pharyngeal artery off of your external carotid artery. And then you also have your dorsal lingual branches off of your external carotid artery. Another question I've been asked is, during an adenoidectomy, what should be left behind? And that's passavant's ridge. Why? Well, that's because a patient can develop VPI, velar-pharyngeal insufficiency. And that is the incomplete closure of the soft palate against the posterior pharyngeal wall during speech and swallowing. So commonly a patient may end up, they're drinking water, that water may kind of shoot out their nose. Another very highly tested question is what are the Paradise criteria? And that's in order to remove your tonsils after several episodes of tonsillitis, and that's 7 infections in 1 year, 5 infections in 2, and then 3 infections in 3 years. Another commonly asked question is, what are the 2 muscles that compose the tonsillar crypt? And that's your palatoglossus muscle and your palatopharyngeus muscle. And then what fascia envelopes the tonsils? That's your pharyngeo-basilar fascia. And then what are your 3 indications to perform just a solo adenoidectomy? That's refractory sinusitis, obstructive sleep apnea, and otitis media after a second set of tubes. And then if you have a lesion, let's say on the inner lip, after someone accidentally chewed their lip, what is that called? It's an oral fibroma. What are some common features of a peritonsillar abscess? That's going to be uvular deviation, trismus, or muffled voice that's described as a hot potato voice. And then how do you treat that? Usually it's via incision and drainage. Moving on to ears. How does one diagnose recurrent acute otitis media? And that's 3 infections within 6 months and or 4 or more infections in a year. All right. An extremely high yield thing is to just go over how Rene test versus a Weber test works. So Weber test, let's go over first like what a normal hearing test will look like. First, the physician will place the tuning fork on the patient's forehead, and if the patient says that it's not louder on either side, it's just midline, that is going to clue you in probably that this is normal. And then to make sure of that, the physician then will do the Rene test, kind of hitting the tuning fork, placing the tuning fork behind the mastoid and then outside, and then just in the air. And then if the patient hears it louder in the air and not on the mastoid, then that's a normal test. And if they hear the air on both sides. If it's conductive, then when the physician does the Weber test, it is whichever side the patient hears it louder, that should clue you in to being a conductive hearing loss, as well as if the physician during the Rene test, that same ear that localized during the Weber, if the mastoid portion, when the tuning fork is placed on the mastoid, then that should clue you into a potential conductive hearing loss. And then in addition, if it's a sensorineural hearing loss, if you do the Weber test, it actually will localize to your normal ear, so away from where you have your sensorineural hearing loss. And then the side where you do have sensorineural hearing loss, you should hear air conduction louder. It's a little confusing. I would kind of watch a video on it just to make sure, but that's kind of the gist. And then something that's important is just going over what the different types of audiograms are. These are pretty high yield. In a sensorineural hearing loss, what you first kind of will see is a slope down, and a commonly asked question is, what is it called for age-related hearing loss? And that is presbycusis. And then when looking at a conductive hearing loss, something to look for is that first you'll see that bone conduction will be within normal range, which is between 0 to 25 decibels. And then for air conduction, that will usually show hearing loss. And then something you'll see is an air bone gap, and usually it's at least 10 decibels or greater between both your air conduction and your bone conduction. Then for mixed hearing loss, usually what you'll see is bone conduction will not be within the normal range. Then air conduction will be even worse than your bone conduction thresholds. So basically what you'll see is your bone conduction will be, let's say, at like 40 decibels or so, and then your air conduction thresholds are going to be about 60 decibels as well. And then just to go over the borders of the different kinds of hearing loss. So normal hearing anywhere from negative 10 decibels to 20 decibels. And mild hearing loss kind of begins around 20 or 25 over to 40 decibels. And 40 to 55 is moderate hearing loss. And then 55 to 70 is moderately severe hearing loss. And then 70 to 90 is severe hearing loss. And then 90 to 120 is profound hearing loss. And then what are the 4 commonly tested causes of conductive hearing loss? That's non-patent external auditory canal, so kind of just wax getting clogged up there potentially, tympanic perforation, non-aerated middle ear, and ossicular chain disruption. Now this next question, this is super high yield. If a physician is cleaning out wax from the patient's ear and the patient begins to cough, what nerve is causing that? That's Arnold's nerve, which is a branch of the vagus nerve. What are the 4 features of Meniere's disease? One, it's going to be tinnitus. Then it's going to be fullness, or the sensation of like pressure in your ear. It'll be vertigo that lasts at least 20 minutes or from anywhere from 20 minutes to a few hours. And then very important to know, it's sensorineural hearing loss. Now, what kind of sensorineural hearing loss? It's going to be low frequency. Another commonly asked question is, when placing an ear tube, what quadrant of the ear? Also important to know, maybe look up what are the quadrants of the ears. Very important just to like when you want to describe like if there's a perforation, knowing where that is. But it's important to know the quadrant of the ears. And then when placing an ear tube, what quadrant do you want to place the tube in? That's going to be in the antero-inferior quadrant. Now, why? There's 2 reasons. One, it's you want to avoid the collateral vessels, so you want to avoid bleeding. And then it's also far away from the ossicles. Question I've been asked before is, what is earwax made up of? It's sweat, sebum, and dead skin. If a patient is feeling fullness in the ear, what should be the most common cause and the lead of your differentials till proven otherwise? TMJ. What are some lifestyle adjustments or kind of treatment for tinnitus? And that's going to be cut out caffeine, salt, and tobacco. And then during a mastoidectomy, what are the 3 main landmarks you want to know? So superiorly, that'll be your tegmen. Anteriorly, that'll be your external auditory canal. And then inferiorly, that'll be your sigmoid sinus. And then another commonly asked question is, what are the landmarks of the facial recess? So that's going to be your facial nerve, your chorda tympani, and then it's also going to be the buttress of the incus. I was only asked this next question once, but I thought it's probably good to know. It's, what is the Fukuda test or Fukuda test? It assesses the vestibular function of the patient, where the patient marches in place for 50 seconds, and if they drift 30 degrees or more, then they have a potential inner dysfunction on that side. Another commonly asked question, if a physician shows you a CT scan and of the ossicle, and they ask you, they point kind of at the ossicles, and they kind of are going to say, you know, what bone is what, kind of remember the ice cream cone analogy, and that's going to be that the cone is the incus, and then your ice cream is the malleus. Let's say there's a patient that arrives with a week-long episode of vertigo with no hearing loss, and then the patient just seems, or the patient reports that they had a cold just prior, but now they've gotten over that cold. What should you kind of think or kind of clue in? A patient would probably then have vestibular neuritis. Another commonly asked question is, what are cholesteatomas made up of? That's squamous keratin debris. A question I've been asked is, where is that found? And that's going to be found in Prusak space. When performing a Dix-Hallpike test, what type of eye movement are you most likely to see? And you're probably going to see a geotropic nystagmus. Why and what canal is it most likely to affect? That's your posterior semicircular canal. So again, geotropic nystagmus, very high yield. Now, what does a tympanometry measure? It measures the mobility or compliance of the tympanic membrane, and this measures the middle ear pressure, which should equal atmospheric pressure in a normal situation. So what are the different types of TIMPs? So TIMP A, that's normal. And then also know, what is TIMP AD? It's flaccidity due to ossicular chain discontinuity or perforation. And then what is TIMP AS? That's stiffness, so just remember AS for stiffness, due to otosclerosis. And then TIMP B, that's described as flat, so kind of like B flat in music. It's due to otitis media or perforation as well. And then TIMP C, it's a eustachian tube dysfunction, so kind of think of it as like C as in like almost like something sucking it in, because that's your eustachian tube almost having dysfunction. So that's how I remember that. And then something you may commonly see during just a scope is the physician may kind of like point laterally once they're kind of going back in the nasopharynx, and they're going to say, what is that like hole that's located in the lateral aspect of the image? And that is usually the opening of the eustachian tube. And what is that called? The torus tubarius. And then dilatation of the eustachian tube occurs via what muscles and what are their innervations? So tensor villi palatini, that's innervated by CNV3, and then levator villi palatini, and then that's going to be the vagus nerve. And then what is a common symptom of a patulous eustachian tube? That's hearing yourself talk and the feeling of fullness. What are some ways to alleviate tinnitus? And that's distracting oneself, lipoflavonoids, ginkgo biloba, and melatonin, and then also CBT, cognitive behavioral therapy, and then also getting a hearing aid. And then what is a common morbid cause of tinnitus? And that's hypertension. A question I've been asked is, what portion of the stapes is most likely involved in otosclerosis? And that's the stapes capitulum. Something important to note, which I will not include in this video, but really go over your ossicular chain anatomy. And when I say the chain, I mean individually going over both the malleus, incus, and the stapes, and knowing what each of them looks like and how each different, similar to the external ear, how each aspect of the ossicle has a name to it. So I would go over those names. What are the two portions of the eardrum? That's the pars flaccida and the pars tensa. And then a follow-up to that is, what are the three layers of the eardrum? And that's your squamous outer layer, it's your fibrous middle layer, and then your mucosal inner layer. And then what's the difference again between the pars flaccida and the pars tensa? It's that your pars flaccida lacks a middle fibrous layer. And then what makes up the internal auditory canal? And what kind of divides it? A common like mnemonic to kind of remember things, it's 7 up and 8 down. So kind of just remembering that your facial nerve is going to be in the superior aspect, and your cochlear nerve will be in the inferior aspect. And then what divides it? It's divided by Bill's bar. What is corner septum? Corner septum is a bony plate that separates squamous and petrous air cells. And then what are the 4 parts of the temporal bone? That's the petrous, the mastoid, the squamous, and the tympanic. What are the 4 ways to surgically approach a vestibular schwannoma? And what is kind of the benefit of them? So what I kind of felt was the most commonly used method was the translabyrinthine. The con of that is that you will lose hearing, but the benefit is that you have much better exposure, and thus you can save the facial nerve. And the retrosigmoidal, you will hopefully be able to preserve hearing, but you potentially run the risk of hitting the facial nerve. The 2 other options are the mid-cranial fossa approach as well as a retrolabyrinthine. What is a very common cause of an itchy ear? And let's say you look in the ear and there's no infection, but the ear kind of looks almost dusty and kind of like white. So you kind of should think about eczematous otitis externa. And how would you treat that? You treat that via lotrazone. What is your auditory nerve pathway? It's your eighth cranial nerve, your cochlear nucleus, your olivary nucleus, your lateral lemniscus, your inferior colliculi, your medial geniculate, and then your auditory cortex. And then what are some contraindications to getting a cochlear implant? If the patient's hearing, if they have severe profound hearing loss, and if their word discrimination is less than what percent? 60%. So they need at least 60%. Moving on to the nasal cavity, allergies, and sinuses. What timeline defines chronic rhinosinusitis? That's at least greater than 12 weeks. Recurrent CRS, or chronic rhinosinusitis, is that which occurs 4 times with no symptoms in between. And then something to know is what kind of TH response. There's one with nasal polyposis and then one without nasal polyposis. And what kind of helper T response? So TH1 is without nasal polyps, and then the one with nasal polyps is the TH2 helper T response. And what are the 4 common presenting symptoms of sinus infections? So you're going to commonly see nasal obstruction, loss of taste and smell, sinus pressure, and nasal drainage. And then what are the 3 roles of the turbinates? It's to warm, humidify, and filter the air. And then what makes up the septum? That's going to be your quadrangular cartilage, your vomer, your perpendicular plate of your ethmoid, and then your maxillary crest. And your maxillary crest is made both of the maxilla and the palatine bone. A very highly asked question is what makes up Kesselbach's plexus? So your anterior nosebleeds, that's going to be your sphenopalatine artery, your greater palatine artery, your superior labial artery, and then your anterior ethmoid artery. During a septoplasty, what plane do you want to be in? That's your subperichondrium plane. Why? Because it's avascular. What is important to leave behind during a septoplasty? That's a dorsal and caudal strut of your septum. Why? That's in order to prevent a saddle nose deformity. What are some common complications that could occur due to a septoplasty? So 4 of them are saddle nose deformity, nasal tip ptosis, perforation, and a hematoma. And then what complication can occur after a turbinectomy and a potential septoplasty? Ozena. What is Ozena? Ozena is also called empty nose syndrome because at that point you've taken like the role of the turbinate, which senses the feeling of air. So now you no longer have anything that's kind of like no longer feeling that sensation of air. So it just feels like your nose is empty almost. What are the names of the 2 incisions that can be made for a septoplasty? One is the hemitransfixion incision and then your Killian incision. What are the differences between the 2? Your hemitransfixion incision is more anterior, which I have found that most surgeons will prefer because it provides better visual. And then your Killian incision is more posterior. Medications are contraindicated during allergy shots. That's beta blockers. What exactly is rhinophyma? It's where rosacea causes chronic inflammation of the sebaceous glands leading to fibrosis of the area. Why do people develop this? They usually have a genetic predisposition. What is Samter's triad? Samter's triad is nasal polyposis, aspirin sensitivity, and asthma. What is the primary blood supply of the inferior turbinate? It's the lateral nasal artery. And then, what is an indication for a middle turbinectomy? What's a common one? It's a concha bullosa, which is what? It's an air-filled cell of the area. So when conducting a middle turbinectomy, what are the 2 things that one should be concerned about happening consequentially? So Less concerning is a mucocele, and of course, more concerning is a CSF leak. Why is that? Because your middle turb connects to your skull base. What are the different kinds of theorized roles of the sinuses, and why do we have sinuses? The one that seems to be the most important is that it lightens the weight load from your neck, but also it warms and humidifies the air. It can potentially help with the sound resonation, and then it also filters, it kind of acts like an air filter. Commonly asked question is, what are the four lamella of the sinuses? And that's your uncinate process, your ethmoid bulla, your basal lamella, and superior turb. And what drains through your sphenoid os? That's your posterior ethmoid and your sphenoid sinus. And then what is the semilunar hiatus? And then what is the ethmoid infundibulum? And what do they drain? So the ethmoid infundibulum is a funnel-shaped space that opens into the semilunar hiatus, which is a crescent-shaped groove or slit that sits within the lateral wall of the nasal cavity. And that functions as a passage through which secretions from the frontal sinus, the anterior ethmoid sinus, and then the maxillary sinus drain. This is a question that I've been asked, is how many turbinates can you have? Now, commonly you have 3, but people can have 4. What's that fourth one called? It's called a supreme one. What is a test that physicians will use to kind of clinically see if an inferior turbinectomy will be beneficial? That's the Cottle maneuver. And what is that? How does that kind of go? It's when they kind of take they can honestly just take their fingers and they kind of spread the nose laterally, and they'll be like, do you breathe better? And the patient usually will say yes. What are the boundaries of the frontal recess? So superiorly, it's the frontal sinus floor. Inferiorly, it's the uncinate process. Anteriorly, it's the ager nasi. And then posteriorly, it's the ethmoid bulla. Laterally, it's the lamina peparischa. And then this is just something to know about the lamina peparischa is, let's say during a fest, the physician sometimes will kind of go, and then they kind of will look at you and just say, why don't I want to go more laterally? And after you kind of say oh, that's the lamina peparischa, and they say, well, okay, why don't you want to go more laterally? That's because that kind of divides the entrance into the orbit of the eye. What are air cells in the sphenoid called? Anode cells. So let's say that you get a 13-year-old male who is having unilateral chronic epistaxis, and then what should you kind of suspect? Potentially a JNA, a juvenile nasopharyngeal angiofibroma. And then what is this considered a tumor of? It's considered a tumor of your IMAX. And then what is Quiros classification? Quiros classification is the depth of the olfactory fossa, specifically the height of the lateral lamella of the cribriform plate. There's 3 types. Now, it's good to know the numbers that divide these 3. So Quiros type 1 is 1 to 3, Quiros type 2 is 4 to 7, and then Quiros type 3 is 8 to 16 millimeters. What are the 2 systemic diseases that can cause septal perforations? Sarcoidosis and Wegener's. What is the area called responsible for a posterior nosebleed? You have Woodruff's triangle, so that's going to be your SPA, your sphenopalatine artery, your posterior ethmoid artery, and then your anterior ethmoid artery. Something I saw once, so if you see a surgeon inject local into the hard palate right before they conduct a FES, and they ask you why did they do that, it's important to just remember that the greater palatine artery is what supplies blood to the hard palate, and that also leads to the supply of the SPA and the greater palatine artery, which also supplies blood to your nose. Treatment of epistaxis workup. So first thing you want to do is spray Afrin into the patient with the nose, and then you kind of want them to lean forward and pinch their nose and put their head down a little bit, and then you want them to do that for 10 minutes. Let's say that doesn't work, then you move on to gel foam. And if that doesn't work, you move on to Surgifoam. And then if that doesn't work, you go to rapid rhinos. If that doesn't work, you go to Epistat. If that doesn't work, you go to Foley. And if and your very last line is embolization. What location is the most common place for a CSF leak during a FES? That's the lateral lamella of the cribriform plate. And then let's say a patient comes to you and then every time they eat, like let's say hot soup, or just every time they eat, they always get a runny nose. What is that called? Vasomotor rhinitis. All right, moving on to laryngology. Important anatomy to know is know the borders of your supraglottis, your glottis, and your subglottis. So know that your supraglottis is the tip of the epiglottis to the laryngeal ventricles. Know that your glottis is your laryngeal ventricle to 1 centimeter below the true vocal cord. And then your subglottis is 1 centimeter below the true vocal cord to the lower border of the cricoid cartilage. So what is it called when you have false vocal cords above the true ones? Pica ventricularis. What is a Zenker's diverticulum? A false diverticulum through the cricopharyngeus and the thyropharyngeus muscles. What's that location called? Killian's triangle. Let's say you have an older male patient who has obstructive sleep apnea with a high BMI, and they come in with a chronic globus sensation, like something stuck in their throat, and they always complain about clearing their throat. What should your suspicion be like right away? It should be LPR. And then what are some common findings of LPR on scoping? So you'll get IA bands, cobblestoning, and then double lines on the cords. Now going over vocal cord musculature and anatomy. So first and foremost, what nerve supplies innervation to almost all the vocal cord muscles? And that's going to be your recurrent laryngeal nerve. What's the only one that is not innervated by that? It's your cricothyroid. What innervates that? The external branch of the superior laryngeal nerve. What 3 muscles are going to be your adductors of your vocal cords? So that's going to be your lateral cricoarytenoid, your thyroarytenoid, and then your intraarytenoid. What opens your inlet? It's your thyroepiglotticus. And then what closes it? That's your area epiglotticus. And then what muscles relax or tense the vocal cords? Your thyroarytenoid relaxes the cords, your vocalis relaxes and tenses a portion of the vocal cords, and then your cricothyroid is what tenses your vocal cord. And then some certain actions that you'll kind of see a laryngologist kind of like make the patient do, and I think it's good to know why they do them, because I sometimes would watch and I'm like, why do they make them make the sound? So if the physician asks the patient to stick out their tongue, they're doing that because they want to examine the base of the tongue. If they ask the patient to puff up your cheeks, that's their way of seeing the piriform sinuses. If they are like sniff in, and that's basically them checking the abductor, so your PCA. And then if they say E, that's checking the adductors. And if they kind of go like say E, that's them checking for like tension. So that's your cricothyroid. Another good thing to know is what like a laryngoscope exam will look like. So that's good to know that anatomy. And the anatomy of your vocal cords. So specifically, what are the layers of the vocal cords? That's going to be a squamous outer layer, the superficial lamina propria, your vocal ligament, which is made up of the intermediate and deep lamina propria, and then also know the vocalis muscle. And then what is Ranke's edema and who is it common in? So it's benign diffuse swelling of the vocal cords with excess deposits of protein and hyaluronic acid in superficial lamina propria. So if you were to get unilateral damage to the recurrent laryngeal nerve, what position would your vocal cord be in? That's going to be your paramedian position of the vocal cord. And then what provides sensory innervation above the vocal cords? And then below the vocal cords. Above, it'll be from the internal superior laryngeal nerve, and then below, it'll be from your recurrent laryngeal nerve. What would you see in a patient that has superior laryngeal nerve paralysis? So you will see someone who has a lower pitch of voice. Think about why. Because if your superior laryngeal nerve is gone, that's not innervating your carpothyroid muscle, which then is causing that it can no longer tense your voice. And then, what is it called when you have recurrent laryngeal nerve and superior laryngeal nerve paralysis? Cadaver vocal cords. And then, what's a common consequence of long-term intubation? Subglottic stenosis. And then, why do you need to wear an N95 mask when lasering a recurrent respiratory papillomatosis patient? That's because HPV can aerosolize. So inspiratory stridor versus expiratory stridor is kind of like, where is that located differently in your in regards to your like laryngeal anatomy. So know that your inspiratory stridor is going to be supraglottic, and then your expiratory stridor is going to be subglottic. You're with a laryngologist and they say they see a granuloma on the vocal cords of the patient, and they ask you where does that occur specifically. You would say the perichondrial space. Let's say you have an old man and he comes to clinic with a sharp pain in his hyoid area, yet they have a clear exam on laryngoscope, nothing else that's like abnormal, I guess, like on his labs. So what do you think could be occurring? And then that's going to be the ossification of the hyoid bone to the thyroid cartilage. All right. Moving on to facial plastics and reconstruction, something good to know are kind of just like the different names of the face, like the different, just how we talked about like knowing external ear anatomy. It's kind of good to know that like this is called the glabella, and then this is called the nasion, and then this is the rhinon, and then know that this is like called the columella. So those are kind of important. So something commonly asked is, what are the nasal tip support mechanisms? So there's three. It's your lower lateral cartilages. It's the attachments of the lower lateral cartilages to the septum, and then also know that the attachments of the lower lateral cartilage to the upper lateral cartilage. And then know the difference between the keystone area and scroll area. So the keystone area is where the nasal bones border the upper lateral cartilages, and then know that the scroll area is where your upper lateral and your lower lateral cartilages meet. And then, when is your time frame to reduce a nasal fracture? And that's within 2 weeks. And then, what are two external incisions that are made during an open rhinoplasty? So that's going to be your transcolumellar and your marginal incisions. And then, what are two internal incisions made during a closed rhinoplasty? It's transcartilaginous and marginal incisions. So what is it called when too much tip support is lost during a rhinoplasty? Polybeak deformity. What are the facial aesthetic regions? So that's going to be your forehead, your eyelids, your cheeks, your nose, your lips, your mentum, and auricles. All right. And then local flaps, they're divided into two different like categories. What are they and why are they divided into those two categories? So you have random like local flaps, and those are, I guess, like they're divided by their blood supply. So for the random flaps are perfused by the subdermal plexus, and then axial flaps will be perfused by using kind of like a dominant vessel for the primary vasculature, one major vessel. What are two reasons to fix a nasal fracture? So cosmetic reasons, and then in addition is obstructed breathing. What bones make up the orbit of the eye? So that's going to be your sphenoid, your maxilla, your ethmoid, your lacrimal, your zygomatic, your palatine, and frontal bones. So good to know those. So what bones make up a tripod fracture? It's your zygotemporal, your zygofrontal, and your zygomaxillary bones. And then let's say if the patient has a tetrapod fracture, what's the other bone? So it's the three that we just mentioned, the zygotemporal, zygofrontal, and your zygomaxillary, and also the zygosphenoidal. And then what makes up your Lefort fractures? So know that Lefort 1 is horizontal fracture through the maxilla. Know that Lefort 2 involves the inferior orbital rim. And then know for Lefort 3, it includes zygoma and the orbit. And then What is the max intraocular pressure before having to do orbital decompression? I saw different numbers, but what I was asked during rotations was 40 was the number. Something that I was also asked once is why are cuts made on flaps during like facial recon and stuff? And that's to prevent hematomas mainly. And then something to know is it better to make a vertical or a horizontal incision during an emergent tracheostomy? And the answer is vertical. Why? Because that's how you know you avoid any like dangerous vasculature or you avoid the nerves. A commonly asked question I got was, what is the reconstructive ladder? So it's closure by secondary intention, primary closure, skin grafting, local flap transfer, regional flap transfer, microvascular free tissue transfer, and then transplants. What are the 3 stages of graft healing? So first is imbibition, which takes place for 24 to 48 hours. Now, a question I was asked was, what does imbibition mean? It means to drink. I think if you know that, that could maybe impress someone. But it's to drink. Inosculation, that occurs over 3 to 5 days. And then neovascularization, which can take a few weeks. What are the 4 indications for inferior orbital fracture fixation? So that's going to be endophthalmosis greater than 2 millimeters, diplopia on primary or inferior gaze, large fracture size greater than 50%, and then soft and tissue entrapment. So those 4. And then something good to know is just kind of the anatomy of the mandible as well, and then just kind of knowing kind of like what portions of the mandibular anatomy is most likely to get mandibular fractures. So know that your condyle is the highest at 30%, followed by a tie with the angle of the mandible and then the body of the mandible, both at 25%. Something I've been asked is, what are the 4 indications for an open reduction and internal fixation of the mandible? That's going to be displacement of the condyle into the middle cranial fossa, the inability to obtain adequate occlusion, lateral extracapsular dislocation, and then contamination of the open joint wound. And then what determines favorability versus unfavorability of mandibular fractures? The vector forces of the muscles pull the fracture together, versus if it's unfavorable, the muscles kind of pulls them apart. And then what is Engel's classification? So for class 1, know that that's a normal bite. That's where the mesiobuccal cusp of the maxillary first molar lies in the buccal groove of the mandibular first molar. And then class 2 is retrognathic, which is like an overjet. And then class 3 is prognathic, which is an underjet. And then I kind of have just like a quick last section of just like general things that didn't really fit anywhere. So something good to know is, what's the max lidocaine that you can give? So commonly they'll say like this patient is 50 kilograms in weight. What's the max lidocaine I can give both with epi and without epi? So without epi, you can give 4.5 milligrams per kilograms. That's without epi. And then 7 milligrams per kilograms with epi. And then something I've been asked is, it's very important to know the number of the teeth, specifically like that this is like 8 and 9 are like your 2 front incisors, I believe, like your central incisors. So really good, just go over, like find anywhere on Google, like just the different names of like all the different teeth and whatnot. Also good to know the different kind of amoxicillin dosing or augmentin dosing. Also important to know like what is synkinesis. That's the aberrant reformation of the neural pathways. And then if a patient is experiencing anaphylaxis, what's kind of the approach in epinephrine treatment? So you first want to give 0.5 milligrams per kilograms. You want to wait 10 minutes, and if no response is given, you can give it again, and then you can give a max of 3 doses. Then lastly, if someone has suspected angioedema, what is the main lab that you want to check for? And then, so that's going to be your C1 esterase inhibitor protein. And then specifically, you want to look at the C4 portion. And then what's a common hallmark of like facial angioedema or like oral cavity angioedema? and that's going to be floor of the mouth edema. So thank you, everyone. That's kind of like the list that I made. These are the questions that I was personally asked. Of course, that this is not all-encompassing of ENT or what someone else may have experienced during their sub-I rotations. I hope it's helpful. Please feel free to like comment back. And thank you and best of luck, everyone applying this cycle. Love this field and hope everyone gets good news in March. So thanks, everyone.